the power has to be optimum, the passenger has to be of average size, the passage has to be adequate. If any of them malfunction, the baby will get stuck. The vacuum will help the power. There is a predetermined pressure that up to what level the vacuum can be created and how forcefully can somebody pull it.
Let's talk about labor interventions and in particular about the process of induction.
So in the process of induction, we want a pregnant woman to go into labor. So that we commonly here we use medicine, but in the medicine we use here is we use a tablet, we call it a misoprostol. So there are women who we classify them into categories who are eligible to use the misoprostol tablet, or there's a group of women who has delivered more than 3 children before. These women are not eligible for the misoprostol. In this group we use a continuous symptometrin group. We call it oxytocin. It's a natural hormone that acts on the uterus to go into contraction. Now in the process of induction, sometimes in certain other countries, we don't practice here. We can directly go and rupture the bag of water. So then the woman will go into labor. So there are, then another option is we also use Foley's catheter. It's called mechanical. We put the balloon in the birth canal in the cervix and put water inside, distilled water, and make that mechanically distance the cervix. And once you disturb it, then it goes into softening. So then there is another medicine we use to put in, it's called laminar tent. Once you put in the cervix, it draws out water and it expands. Then in the process of expansion, it opens up the mouth of the womb. So for a successful induction to lead to a good normal labor and delivery, the mouth of the womb has to be riped, softened. So the mouth of the womb in a woman who is not in labor will feel like your nose tip. It's firm.
Yes.
So we use the tablet misoprostol, we use the Foley's catheter, we use the laminar tent to make the womb go soft like your ear lobule.
Yes.
So your ear lobule feels very soft.
Yes.
So that means the mouth of the womb is ripe. Then once it is ripened, then we use another medicine for the upper part of the uterus to contract. That is the oxytocin, the central drip. So here, when we have a protocol with each of these, if we use the misoprostol tablet, because of the risk that this can cause violent contraction, we have reduced dose, like 25 microgram we use, and then we pace it over 4 to 6 doses we put, and at each interval we leave minimum of 6 hours in between, and we see. So if a woman has received 4 doses and still not, the womb mouth is not ripened, then we call it failed induction.
Yes.
Then we may extend 2 more doses, and total of maximum of 6 misoprostol dose is taken as a package to make the mouth of the womb ripe and go for proceed with the induction. If the woman's cervix still feels like your nose firm after 6 doses of misoprostol, she is categorized as a failed induction case and put for elective or planned cesarean section. With the Synto we use on the dose of the medicine depends on 5 units we use or 10 units we use, oxytocin drips. We use 2 bottles in 1 day, and the second bottle is at a higher dose than the first one.
Yes.
And we use, then we can repeat it on the next day if it's still not favorable. So after 4 bottles of oxytocin, if the womb doesn't open up, we also categorize as failed induction.
Yes.
In Bhutan, we don't wait up to 42 weeks. In Bhutan, all women in the whole country who has successfully completed 41 weeks of pregnancy, we advise them that that is the time they should get admitted. We wait beyond the completion of the due date of 40 weeks for one more extra 41 weeks. There's a substantial group of women who will go into natural process of labor, and then they have a much easier way to deliver faster and better with less complication. But there's a certain, as I mentioned earlier, that around 10% of women who will deliver after the due date. In these group of women who don't go into labor during the waiting period by 41 weeks, the rest are mandatory to be admitted after completion of 40 weeks to the hospital for delivery. These are the group of women who are directly eligible for induction. That means these are the group of women in whom we try to bring artificial onset of labor pain. And if we fail, we resort to cesarean section delivery for this group.
What about epidural? Are there women who are still opting for that? And what are some of the, definitely the benefits, but I was wondering the side effects too, if it has?
Epidural analgesia, we call it. And in the plain words, it's called painless labor or painless delivery. It is a gift or a surah from our queen to the women of Bhutan since 2016 February. So it has been started in our birthing center. At the beginning, people were skeptical, and we had to explain the procedures because it was not there as a package. We didn't have the opportunity to explain the mothers during the course of pregnancy. Actually, when you talk about epidural, the story starts during pregnancy. The women come for repeated checkups. We have antenatal health education sessions. We have antenatal discussions, antenatal exercise. During those, the topic is discussed with the woman, and it is explained to the woman that what epidural means. Here we offer epidural to women who they opt for, that they want epidural. So the condition is that the woman doesn't have contraindications, that she doesn't have infections in her lower back, she doesn't have bony deformities, she doesn't have infection elsewhere in her body, she is not allergic to the medication. So then she is qualified to receive epidural, and epidural is given in our setting by anesthetists who come on a roster basis to the birthing center. And women, when they actually go into labor, the minimum criteria is their womb, during the process of labor pain, the womb should open up to minimum of 4 centimeter opening. Because if a womb doesn't open up to 4 centimeter, it may be a false labor. So then they can get stuck there. So if the womb is definitely open up to 4 centimeter, we are very sure that that is going to continue and then deliver. So at 4 centimeter dilatation, where they experience the initial phase of labor pain, then this epidural injection it's put through a needle. A medicine is put into the spinal canal without piercing the nerve roots. It's outside the nerve roots are hanging in the spine, and there's a coating. This is called epidural covering. So when the injection is put inside, it will just go outside the nerve covering, and it gives a anesthetizing effect on the nerve roots leaving the lower part of the body. So the dose is such that it will not affect the motor tone, but the dose of the drug is calibrated in such factor that it will only numb the sensations. So the mother will be able to move around, but she may not feel the pain. But it is not totally painless, because when the head is we divide labor into first stage, where she actually reaches up to the point of 4 centimeter. Is the first stage of labor. Then second stage is when the cervix starts to open up and go to a maximum full opening up to 10 centimeters. This is second stage. And third stage is when the baby actually goes through this dilated cervix. In the second stage of labor, when the baby is actually being delivered through the birth canal, it's quite even painful, even with epidural. Some degree of pain. On a scale of 1 to 10, without epidural, women may be feeling pain maybe up to 8 and 9. But with epidural, women will be feeling a pain about 5 to 6. So the intensity of the pain is blunted down. But since you asked about the side effects, epidural is not a one-way straight cut ticket. It also has turns and rounds. Once a woman is on the epidural, sometimes if you do not monitor closely, the mother's body can react suddenly that her BP can go down, and it takes time. If her BP goes down, then the blood flow to the baby is reduced. Baby go into distress. Sometimes we need to go for a crash cesarean section because of profound hypotension from the epidural. That is the mother's body reacting in an unusual way. And on the other side, if this doesn't happen, epidural is on and mother is on labor, because she cannot feel the sensation, the urge to push is blunted by epidural. The time of labor get extended by 1 hour more. If we say that one woman can, without epidural, should deliver in 2 hours, the woman on epidural should be given 1 hour extra, 3 hours. So the duration of labor is also extended. Now, and at the end of 3 hours, the woman without epidural, she has a full sensation in her perineum. Once the fetal head touches the perineum, she has an urge to push it out. She will keep on pushing, and that actually helps the speedy delivery. But in a woman who has received epidural, her sensation is blunted. Even if the head touches on the perineum, the sensation to urge to push is not there. So there is a miscommunication between her motor tone and the sensation. So there's a delayed pushing. So in this woman, we use the vacuum delivery. Because here we are having problem with the power. So we use vacuum delivery too. So instrument delivery is slightly increased in the group of women who receive epidural.
Could doctor explain to us about the precipitate labor? And generally people think delivering a baby faster is it's easy and it's good, but apparently it's not.
Usually in a normal woman who go into labor, if you are a first-time woman undergoing labor, your cervix is supposed to dilate at least 1 centimeter per hour. So if it dilates from about 2 centimeter to 10 centimeter, we are talking about 8 hours, because per hour dilatation is 1 centimeter. In a woman who has delivered previous baby, the rate of cervical dilation is little faster, 1.5 centimeter per hour. So we are talking about 6 hours. 6 hours in a woman who has delivered before, 8 to 10 hours in a woman who has not delivered. This is a normal duration of labor. Now when you deliver that time period in 3 hours, then it is called precipitate labor. So the woman just goes into labor and delivers the baby and the placenta so fast. What can happen is when the precipitate labor comes, there's a risk that the woman is not in a correct position to deliver. Okay. So the woman will deliver standing or in a sun position where the force of the labor is quite strong, that it will push the baby out forcefully. Baby will hit elsewhere and get injured. So fetal direct injury is very high risk, because the force of labor is so high that she can have a very nasty perineal tear. Okay. And usually these are group of women who deliver very easily the precipitate labor. These are the group of women who has a very poor perineal support muscle. It's bad news, because after certain years, their uterus, their urinary bladder, all will sag down. It will just be hanging down, and the uterus comes out. We call it genital prolapse. So there will be incontinence, and the organs will be hanging out, the loose perineal support. So it's bad news for the mother who has precipitate labor. Because in a very healthy woman who has a very good perineal tone muscles, normal muscles, they will not have this problem later in life. So precipitate labor is not a good, both for mother and both for the babies.
Do you think pelvic floor exercises would actually help you from having precipitate labor?
No. Precipitate labor is something that is genetical in origin. The woman also doesn't have control. So it is definitely the exercise may be there. She can learn it to reduce the long-term complications after having a precipitated labor. She can still go on doing the exercise after the delivery, but the exercise will not prevent her from having precipitated labor.
So what are some of the advice that doctors would normally give to those women who have a history of giving birth within short amount of time?
We have scientific evidence that most women will go into a natural labor after they reach 37 weeks. So we tell them to be careful and pre-plan, that they should have the bags ready, they should have transports arranged, they should have people identified at short notice who will accompany them to hospital and which hospital they will go. And if they go there, if it's possible, pre-connect with people who can be identified. So we are there to help them. So this is the health education we try to explain to them. But there's no way that we can modify somebody from not having precipitated labor.